Situation will be something like this, right? You knock on the door, provide hand hygiene, right? Patient privacy. Hi, my name is Hai. You'll be a nurse today. Nice to meet you. And then you go right into it. So today we'll be performing your complete head-to-toe exam that includes the musculoskeletal section integrated into it. If you have any questions at any point in the exam, please let me know. Okay, and then as you do it, you can also throw in questions to be conversational. Say, oh, do you have any chest pains while you're doing the heart assessment, etc. So keep that stuff in mind. But anyway, since you're standing there, let me go ahead and have you tiptoe for me on your heels. Can you squat down at all? Back up. Can you touch your toes? Can you bend back to the right, left, twist, twist, shoulders forward, up, back, forward again, back this way, neck forward, back, right, left, churn and churn. And you can throw in one or two of those neurological tests. Can you do a tandem walk for me? Great. All right. So that's just, you don't need to do too much at this point. Okay, good. And she kind of showed off by going backwards too. So just by, I'll talk about the details. I'll break it down later for you guys. Okay. Now let me have you have a seat up here. Have your hands straight out and just spread your fingers. Keep your fingers open. Keep them open. Gotta work on your finger exercises. Go ahead, squeeze my fingers. Squeeze it tight, tight, tight. Good. Flex towards you. Pull, pull, pull. Push, push, push. Okay. Out. Push out. And then pull in. Good. Okay. And then same thing with your feet. Can you push out, kick out, and pull back? Pull back, pull back. Okay. Toes up. And then can you flex down? Okay, good. And then I'm just checking a couple of things there, right? So neural, musculoskeletal is all there. Let me go ahead and have you shrug your shoulders. Shrug your shoulders. Up, up, up. Turn your chin towards my hand. Other way. So those are cranial nerve stuff. Smile for me. Okay. Eyebrows up. Move up your cheeks. Great. Thank you. And then, so you can approach it any way you like. I'm just kind of throwing it all out there. But if you want to go more systematic, you can always just go from head to toe, right? So now with my head, I'm just going, okay, no more cephalic, no pests or anything like that. Facial space, face is symmetrical. Let me have, I missed that. Let's go. Give me a second.
Do you want a general survey too? For the head to toe, or is it just the physical assessment?
Just the physical,
okay.
But I'm just showing you, let me just show you a couple of rounds, different assessment techniques, right? So that one was just literally throwing out whatever you got. So like she was standing, doing those range of motion. She's sitting, I'm doing a couple of things with her. And then as she's sitting here, I'm doing a couple other things. All the hand stuff is done, right? And I'll just listen to your heart and lungs. Of course, she'll be in a gown, right? So just listen, take a deep breath. Breathe out, deep breath. Okay, breathe normally. Deep breath. One more. Good. We'll have you lay down and I'll check your stomach. Pain there?
No.
Pain there? Pain there? There? Deep palpation, right? Pain here?
No.
Pain here? Take a deep breath. Any pain there?
No.
Pain there? No. Nothing at all? Great. Okay. Maybe sit back up. So, what system did I miss? Besides, I don't have a reflex hammer, so you can do reflexes, you can do a little bit of sensation, cap refills, pulses, carotids. You can throw those in extra, but that's enough to pass you. Why? It covers. Okay, so we'll break it all down. You guys really need to record on this. It's special. Well, the way I like to break it up is when they're standing, sitting, and laying position, so that way I don't miss any systems. This actually covered pretty much everything. We didn't really go into details with the lymph nodes and stuff. I want you to throw that in there to get you above. That was just very, very raw, bare minimal, right? I want you to go above that slightly, add in those lymph nodes, check the cranial nerves, check those reflexes, and then throw in more words.
Do we have to tell you what we're doing and what we're checking for and why we're checking for it? We just do it and then, okay.
Yeah, but you can. You don't, but you can. So that was very raw and very core basic of like a head to toe, right? a thorough version would include the cranial nerves, like vision, lymph nodes. You can talk about trachea, carotids, pulses, throw in more words like, oh, do you have any abdominal pain, difficulty breathing on exertion at rest, your skin distribution we'll talk about hair distribution, etc. But let's break down everything that we just did there, and I'll tell you why that looks so efficient. That literally took like 2 minutes, right? Why that gave me plenty of clinical data. Let me have you stand up. So when I asked her to tiptoe for me, right? We're looking at calf strength, quadricep strength, right? Exactly. We're looking at Achilles tendon. We're looking at range of motion all the way from the toes to the ankles, right? And then when I told her to get on her heels and walk, that kind of impact, if you have any spine issues, that's going to register as pain. If you have stenosis, any kind of spinal problems in the lumbar region, that's going to cause pain. Okay, and then the next part of it is look again at the range of motion, ankle, knee, and hips. So when she squat down like that, I'm seeing full flexion of the ankles, full flexion of the knees and the hips. You see that? And then what you want to do on top of this is add the duck walk to really see strength of the hip. Okay, so that's a big assessment finding. If you're able to do that, you don't need to, and I'll show you how to check it in terms of passive range of motion when she gets on the table. Okay, and then back up. Now the next part is you touch your toes. We're checking for flexion of the spine. Can you go ahead and bend back? We're checking for extension of the spine. Can you bend to the right? Lateral flexion, left, right? To see if there's any arthrosis or any kind of issues there. And then twist and twist, right? So full range of motion of the spine, full range of motion from the ankles, knees, hips, and we got spine. Now moving forward, arms forward, up, back. This is external rotation of the shoulders, and then forward, back this way, internal rotation. Another way to test it is external rotation, internal rotation, okay? So full external, internal rotation of the shoulders, and if she can do this, is circumduction of the shoulder also, okay? Another one might be abduction and adduction, right? Then the neck, did I do the neck?
Yeah, you went down.
Neck forward, back, right, left, turn and turn. Same thing, that's basically the spine, but for the neck.
I know when you're dealing with patients, you shouldn't use medical jargon, but for the purposes of the test, if we told them to adduct, would that be okay, or do you want?
It would be okay, but like you said, it's not going to help you clinically. So a lot of times I would just just do as I do, forward, up, back. And you bend forward and bend back to the right, to the left. Keep it simple. That's fine. And you don't need to show off your lingo. But
well,
that's
helps drill it in your head.
Sure. When you document, you want to say, full abduction, adduction, etc. Right? So we got neck, we got spine, hips, knees, ankles, and we got shoulder. When she put her hands up, I'm checking strength of the fingers, grip, full flexion of the fingers, and grip strength, right? I didn't really check her wrist or her elbows too much, but that's something that you might also want to do. We did cranial nerves again, and then neck strength. So we even at this, that's actually a little bit more than what I would normally even do, since she's healthy adult female, right? Smile and all that stuff. That's actually even a little bit more than what I would normally do. So that covers pretty much all of your range of motion, right? Maybe the jaw, something you might want to do. So that covers my range of motion from there. Let me have you have a seat. So when she's in a sitting position, so you could have had her done the range of motion as standing or as sitting. You could have done that range of motion. When she's sitting, I have access to her back. That's why I went for, can you listen? I'm listening to the upper lobes, right? And then breathe. And I told her stop breathing. Or just breathe normally. And I'm isolating heart sounds. And then I move around just a little bit. I didn't go, okay, ape to man. Right? Sometimes I would go back and do it. If I hear or don't hear something, I'll go back and do a full respiratory. Those are focus exams, right? You're gonna spend there all day if you really do everything. But it's in your pocket now. Pull it out when you need it, right? So I got my upper lobes, heart, then lower lobes here, right? And then the middle, I'm subjectively listening. So, okay, I probably got the middle lobe somewhere in there, right? So good, clear lung sounds. And I could hear it through her shirt. So I'm like, okay, I don't really need to really go in deeper. But always skin if you can, okay? Especially when you're first starting, otherwise you miss a lot. Then I was done with that. At this point, actually, what would be great is actually if you can get your otoscope going, right? And you're just looking at the ears, checking the nose, breathe in, cover one ear, so it's for pain see, for check the sinuses and say ah, check the mouth, right? And you want to also throw in stuff like, okay, I'm checking lymph nodes. Okay, swallow. Okay, swallow. Right, so you're checking thyroid and then trachea midline, sure. And I already did the neck range of motion, all that jazz. So that covers my head, chest, right, heart and lungs. And then when I have it laid down, the only body system that I didn't check left was basically abdomen, right? And that can include the pelvic region too. You know, pain here, suprapubic area. So pain here, pain there, no. I went straight over here at the costo-vertebral angle, and I'm just doing the duckbill maneuver. Any pain there? And I put my thumb in that area, the epigastric, if she's an alcoholic, if she smokes a lot, right? Take a deep, or like this, any pain there in the epigastric region for gastritis. Check on this side, duckbill again. What I do is actually I put my index finger, try to get it under that rib cage and say, take a deep breath. So what sign is that?
Rebound?
Huh? Murphy. And then this is the duckbill for that kidney stuff. So that I covered some special tests too, but I got the basic abdomen, right? And then so if you didn't do the squat, or if you want to go above and beyond, the way you would check for the range of motion again is, you know, inversion, right? So this is her ankle sprain. If I inverted it and caused pain there, that could be an ankle sprain at the calcaneofibular ligament, right? Eversion, deltoid ligament strain, very atypical, but it does happen. So you're checking inversion, eversion, Holman's, and if you want it to, Dorsey. What's this called? This motion.
Dorsiflexion. It's not Holman's saying it's
Yeah, dorsiflexion. Good. And then what's this? Plantar flexion. Right? Plantar flexion, dorsiflexion, inversion, eversion. Good. Now, what is this movement?
That's a Holman's.
Hyperflexion?
Yeah, so I'm flexing the knee and flexing the hip, right? And then I'm rotating.
Abduction.
What am I doing to the hip? I'm rotating the hip, right? So external and internally rotating the hip. If you can visualize the acetabulum and if it's moving, so for example, if I'm pushing this way, I'm rotating it in. So that's actually inverting that hip, right? Everting. And then here's a special test for you since we're doing a couple of them. Before we get to the hip, let's start with the ankle, okay? An interesting one is if you do a Tonson squeeze, if you squeeze her calf here, you just relax. You might not be able to do it with her shoes too much, but if you squeeze her calf, her legs should kind of flex down a little bit, right? And there's no pain in the Achilles tendon. If she's on fluoroquinolones or like medications, these things can rupture. Textbook-wise, never seen it, but some tenderness in the Achilles tendon there, right? So that's called a Thompson squeeze. You can also grab the calcaneofibular bone here and then just shift it forward and back to check for stability of those ligaments. So these are called the drawer sign for the ankles. And yours a little bit lax, but it's not too bad. Okay, and then inversion, eversion test, right? You go into the knees, the special test is here. And this is not, you don't need to do it for the exam, but you could do it for your mother if she sprained her ankle. So anyways, with her knee, a couple of things. So for example, this one, have her relax her quadriceps. You should be able to have mobility of the patella. This is called the patellar grind test. Ballottement test would be you're pushing on one side and you actually feel bulging on the other. And that might be a joint effusion, right? Another sign to see if because the ACL and PCL are anterior cruciate or posterior cruciate ligament crosses like this. You can shift it forward and back, and if there's laxity, if there's movement on there, that might be an ACL or PCL tear. And a lot of times when I do that, there's some pain, and that might be an ACL rupture or something. And I asked her, so what happened? So I was running and I stopped abruptly. I heard a pop, forward motion pop, ACL type tear, positive anterior drawer sign for the knee. Okay. What if I thought it's a meniscus tear? So there's a meniscus here, and lateral and medial meniscus, posterior, anterior, right? There's 4 compartments. So what you want to do is, that's called a Mcmurray sign if it's positive. Say if it's positive here, basically you're taking your tibia and you're pushing it against your femoral condyle, and the meniscus is right here. And if it's torn or inflamed, you're grinding that. So this is a Mcmurray sign. Okay, and then that'll be positive Mcmurray sign for lateral meniscal tear. Another finding for meniscal tear is if you touch in the lateral joint space and there's pain, so you can describe it as a lateral joint tenderness, right, with a positive Mcmurray sign. So those are 2 symptoms for meniscus type tears. Okay, another one for here you have the medial counterlateral ligament and lateral counterlateral ligament. What you want to do is, if you push pressure on that, any pain, and you put pressure here, those are stress tests for those counterlateral ligament integrity. So if she had a strain here, when I'm pushing this, I'm pulling that ligament apart, and if there's pain, that causes inflammation. That triggers inflammation. She says, yeah, there's pain here, so that'd be an MCL sprain. Push this way, lateral stress test, MCL, lateral counterlateral ligament strain. Does that make sense? So those are your knees. You want to go forward? You guys tired? This is for fun. You want to get forward? You can see? Come here. Come up here.
Get closer,
buddy.
KK.
Yeah. Get closer. So that's your ankle, that's your knee, and then your hips would be if you were to do this motion, and then I did. Does that hurt?
No.
So sacroiliac joint pathology, inflammation, can cause, if you did that motion, you're stressing that sacroiliac joint, and if there's inflammation, disease of the sacroiliac joint, that'll cause pain. So that's called the Patrick-Febrer test. Okay, so that'll be that. Another one would be, say, if there's a stress fracture anywhere from here up, if I went and did this, that's called the periosteum, and that's where you have a lot of nerve fibers causing that pain. Okay, so that's that. And we already did. Here's a good one that you always see if anyone has sciatica or your parents or anybody. So if she's okay now. It's kind of crazy when you actually see it happen. You raise her leg up, and she's like, ow, 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 right? A shooting pain down this leg. That's a positive straight leg rise test, and it's very pathognomonic for sciatic nerve or any nerve impingement. And then what's interesting is, you're saying there's pain down this way. I flexed it. Now I took the pressure off that nerve. Like, oh, pain went away. Very weird, right? Another one would be the toe test, where you just kind of pull that toe up and you can actually stress that nerve and it causes the pain too. So that's straight leg raise test versus kind of like, huh?
How can you fix that someone has that pain?
It depends, depending on the severity of the impingement. Sometimes it's the muscle, the gluteus maximus, that's pushing in the sciatic nerve. You can go in and inject it with steroids, do physical therapy, stretch that muscle out to relieve that pressure. If it goes deeper into the spine, where you have bilateral shooting pain on the legs, then you're gonna have probably could be surgical. Again, corticosteroid injection into the spine, that kind of deal. Okay, so straight leg rise tests for those nerve impingement type deal. We already talked about the abdomen stuff. Remember, those are muscle stuff too. And don't forget your reflexes if you ever care to show off those. So that, when she's laying down, that basically covers all of your leg stuff. Okay, let me have you sit up. Thank you. You had no idea that you're gonna be up here this long. You're not done yet.
Oh.
Right, so if she was a tennis player, and then she's like, oh, my elbow hurts, right? So what you want to check is, remember your anatomical man, lateral, medial, right? You push here, and you're like, ouch, 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 right? You suspect lateral epicondylitis. Well, a finding for it, if you want to be sure, is have her wrist like that, and then keep it there, okay, against my me pushing on it, and then when you try to push against her, resisting of her extension of her wrist, resisting her extension, and she causes there's pain here. That's a positive resisted wrist test for lateral epicondylitis. Okay, now. So that's if she was a tennis player. If she was a pro golfer and you came in, it's like, my elbow hurts, and you felt here. Now, you felt the medial epicondyle. We're not talking about the olecranon, the funny bone, right? So if you felt here and there's pain, and you'd say, go ahead and hold your wrist in flexion, like that, okay? And then I'm pulling against it, and she has some pain in the medial epicondyle. That's a golfer's elbow, or medial epicondylitis, okay? So those are. And then, of course, you're testing flexion, pronation, supination, okay, of that elbow. None of this you have to demonstrate on the physical. Remember what I showed you for physical was enough with the addition of those lymph nodes and all that jazz. Now, so that's her elbow. Now let's talk about her hand. So she came in for some hand/wrist pain because she was gardening all day, and you weren't really sure what it was. And you asked, oh, I was a human resource specialist, and I spend 9 hours on the computer every day with poor ergonomics, right? So you're feeling, and you want to feel every metacarpal bone to see for fractures. Typically not likely in her mechanism, but sometimes you'd be surprised. So no fractures in those bones. The bones are fine, right? If there's some pain when you stress those bones, there might be something depending on the mechanism, right? What you want to do is check each of these fingers, right? And because fingers should flex, but there's so many joints here. There's the metacarpal joints. What is this one here?
This, the actual bone right here?
Yeah, well, this joint.
Proximal phalanges.
Interphalangeal joint.
Oh, yeah.
So this is
That's what I meant.
your pips and your dips, right? So proximal interphalangeal joint and your dips, distal interphalangeal joint. So any pain in the proximal or distal, this is great for describing cuts. There's somebody there. You want to open the door? So if there's a cut here, you can say at the DIP level, there's a laceration of the third. So the way you count fingers is 1, 2, 3. Third interphalangeal, laceration of the third finger at the DIP level, posterior surface, for example, right? So you want to check those joints, and you want to check for its mobility. Triggering is very interesting. Remember those A1 pulleys we were talking about? So you have these extensor flexor tendons that when she contracts, it pulls her fingers this way. So keep it there. Keep it there. Try to keep it, yeah. So you see these tendons. These aren't veins, okay? Don't do IVs on them. These flexor tendons actually kind of go through the carpal tunnel, and it spreads out this way, and it'll contract that way, right? So you want to feel for that A1 pulley, and then when you did that, there's like, oh no, it got stuck. That would be trigger finger, right? If you pop out there was pain, that would be very pathognomonic for trigger finger inflammation of that flexor tendon, that A1 pulley system. Okay, and then as you go forward up here, something you want to do is tap that carpal tunnel, and basically you're stimulating that pressure. Do you feel any shooting pain or anything? And if you do, and you get that distribution through that radial nerve, then that could be a positive Tandem sign. Okay, a failing sign would be, can you go ahead and grab your wrist and just do this, and just have them wait for a couple seconds, 30 seconds, a minute even, and then it's like, oh yeah, I'm starting to feel tingling in my fingers. Those would be positive signs for carpal tunnel, CTS, carpal tunnel syndrome, right? You ready for one more, or you guys?
Yeah.
What do you do
Information
with
over.
someone who has a
Trigger finger. You can inject the A1 pulley with steroids and to drop the inflammation. Rarely, probably 20-30% of patients can get away with just some oral steroids and some exercises and a little bit of icing, but a lot of times the injection is where it's at. Another thing that you might need injection for, so we talked about injections there, here, and another one would be, this is remember, she's a typist. therapists don't get carpal tunnel typically. But if she was a bus driver or a jackhammer operator and it's chronic impaction to that carpal tunnel, then those can trigger carpal tunnel. And the corrective thing is injections. If not, they'll cut it open and just release that carpal tunnel. Now, one last one for the wrist is if she fell in an outstretched hand, and it's so pathognomonic for scaphoid fracture that they have a name for it. So it's called a Fuchs type injury, right? Fall on an outstretched hand, Fuchs type injury. If you type in Fuchs injury, it's almost like, okay, there's a scaphoid fracture. So your scaphoid bone, when you fall, skier's thumb, sometimes, with hyperextension, you fall on a outstretched hand, you can have scaphoid type fractures. And the symptoms for that is one, Finkelstein's maneuver. This is Finkelstein's, and you have ulnar deviation of that, and it causes some pain. Another one is CMC, or carpal metacarpal joint pain. That would be very specific. So you get CMC tenderness and a Fuchs mechanism. So that could be a scaphoid fracture. Even if the X-ray is not negative, you're going to treat it like a fracture because X-rays aren't as sharp as your MRI hands. Okay, so those clinical findings are important. Another one would be, and this one's the hand surgeon that taught me this. They keep your thumb up and just keep it up there, and you can see these tendons. Okay, you got the extensor tendons here. So you have this thumb extensor tendon, and if you palpate that, you touch it, and it causes pain. Does that cause you any pain? That would be very consistent with a tenosynoviitis or a Decovain's tenosynoviitis. You can Google Decovain's, okay? And that's an injection. Repetitive type injury, gripping and stuff can cause the tenosynoviitis. So it's at that tendon, not the CMC, but at that tendon. Some people are like, oh, in that area? Yeah, Decovain's. It's that one, okay? So that's your hands, wrists, elbow. You want to do shoulder? You're tired.
I'm not doing anything, so.
All right. So with shoulders, you did the range of motion. It tells you a lot. If she does all of that, already shows that you have those muscles, those four tendons, that they're pretty much intact and they don't cause any pain. Some specialized tests for these are, for example, the empty can test, where you take the shoulder and you pronate and it causes some pain. It could be a specific tendon under your scapula that's causing that pain. But really what the idea is, you're taking that bone and you're grinding it against that joint, and how you grind it can give you an idea of where the injury is. So for example, if this literally is called the apprehension sign, where you're about to touch her. She's like, no, don't touch me, right? So that's like that's an apprehension sign, which is like very consistent with a dislocation, where she's afraid. Okay, so that's an apprehension sign for a shoulder dislocation. You can palpate the AC joint, the acromioclavicular joint, and there's that tiny little cartilage in that area that can get inflamed, and arthritis kind of thing, and pain there. So that's very that's one way to clinically see that. You have her arm in the abducted position, and then this is what I always like to do, and I push against it, and she says, ow, ow, ow. That's a supraspinatus tendon that allows you to do this. And what I do is when I push it down, it's pulling on that tendon, and if it's inflamed, then you diagnose a supraspinatus tendinitis. And if she couldn't even do this, can you lift your arm up? And she's like, right? Something's wrong with the tendon. Another one for internal derangement of the shoulder, or anything going on with the shoulder that might warrant an MRI, would be if I flexed her elbow and I did this. I'm trying to grind that shoulder, and I'm taking that joint, the ball and socket, I'm just grinding it. And if there's any internal derangement or inflammation of those four main tendons, then that will cause pain. That's called a positive impingement sign, right? So if I did this, right, and she's like, how positive impingement sign for some kind of rotator cuff issue. Now if I did this and I just kind of twisted it like that, right, that's called a positive Hawkins sign. So Hawkins sign is another way to grind those tendons just to see what's up. Another one, there's a lot, right? Is if you have her hand towards her belly and then push towards her belly button, push, push, push. And if she doesn't have good strength and reports some pain, there's a specific tendon, the infraspinatus tendon, that actually allows you to do that motion, and then that can be damage or some kind of pathology on that one. The last one is a lift-off test. You take that hand, right, and then you just have her lift her arm off. Can you go ahead and lift your arm off? And she's able to do it fine, no pain. And that is specific for another very specific tendon. So that's
Yay.
we covered, exactly.